afternoon. I'd like to welcome you to the Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities. We're delighted to see all of you here today for a program called Overdiagnosed, Making People Sick in Pursuit of Health. In recent decades, growing enthusiasm in medicine and in the population at large for early diagnosis has engaged many doctors in a systematic search for abnormalities in persons who are well. While physicians, patients, and the press tend to focus on the potential benefits of screening practices and early diagnosis of conditions like cancer, Dr. H. Gilbert Welch in his work has exposed the often ignored harm associated with the practice of overdiagnosis. Diagnoses have been skyrocketing for a great many conditions, including breast and prostate cancer and other cancers, hypertension, osteoporosis, diabetes, even prediabetes. Yet many persons given these labels are destined never to develop symptoms, much less die from their conditions. They are overdiagnosed in Dr. Welch's terms. And as he points out in his writings, including this book, Overdiagnosed, which the UVA bookstore has available just outside the auditorium, in his writings, he's pointed out that overdiagnosed patients really can't often benefit from treatment because there's nothing to fix. But they can be harmed, and understanding the trade-offs involved is critical. Dr. Gilbert Welch is professor of medicine at Dartmouth Geisel School of Medicine and a researcher at the Dartmouth Institute for Health Policy and Clinical Research. His findings around the concept, associated practices, and implications of overdiagnosis appear regularly, besides his books, in the medical literature and also in the op-ed pages of leading newspapers like the New York Times, the Wall Street Journal, and the LA Times. There is a list in your handout of a number of articles from the medical literature and also some of the op-ed pieces. We're delighted to welcome Gilbert Welch to the Medical Center Hour, and I'll say that this is better late than never. I say that because 2 years ago he'd been scheduled to speak here, but Hurricane Sandy swept up the Jersey coast and across New York City and up into New England in such a way as to scuttle his visit. His hour with us today should include generous time for your questions and comments and a lot of good conversation. So please join me in welcoming Gilbert Welch on Overdiagnosed.
Thank you very much. Is this mic on? Good. Hi. How are you? So, if I could have my slides on. There we go. Good. And maybe the lights down just a little bit for some images and stuff. 59 years ago, I was born a privileged white child. It is what it is. That's my history. And this is a picture of me. Just so you know, it's actually from Virginia. I was born in Alexandria, Virginia. And some of the clinicians in the audience will immediately recognize there's certain things wrong with that child. That child is clearly overweight. Probably has toddler hypertension, hyperlipidemia, glucose intolerance. And maybe we need the lights down a little bit more. Let's just really take a look at that face. I mean, I know it's an old Kodachrome, but the pediatricians have a term for that. That's an FLK. That's a fun-looking kid. I probably have a bunch of single nucleotide polymorphisms, a couple of genetic variants, and maybe even a frame shift mutation. But the real question is what is going on in there? Look at that. Could that be an early abdominal aortic aneurysm? I don't know. Boy, I'm glad I was born 59 years ago. This is today. This is Chicago O'Hare Airport. Some of you undoubtedly have been there, changing planes. And you've seen this kind of advertisement. This is for IBM, medical histories that alert doctors before patients get sick. And we've sort of been taught to think, boy, that's a good thing. Wouldn't it be a good thing to alert doctors before we got sick? And then all of a sudden, if you're a doctor, you're thinking, man, that could be a lot of alerts. There are a lot of people who are before they get sick. So I want to sort of look at things in a little bit of a different way today. The title of the talk is the title of the book. You've already heard, Overdiagnosed, Making People Sick in the Pursuit of Health. But what it really does is question a widespread presumption, namely that the best strategy to keep people healthy is through early diagnosis. And I'm going to ask questions about that. First, I want to start with a disclaimer. The views expressed here do not necessarily represent the views of the Department of Veterans Affairs or the United States government, which has been my employer for about 30 years. And by the way, you can say this of many of my views may not represent those of the United States government. That's okay. I also have 2 books, and my field is awash in money, and you should be, oh my God, here's a guy hawking books. I want to be clear, I have no financial interest in the books. I made the decision early. I knew this was an uncomfortable message. I didn't want to be making money off it. All the royalties go to charities in the upper Connecticut Valley, Vermont, and New Hampshire. Of course, I have a strong professional interest, having written a book that if you were interested, I'd love to have you read it. You can buy it on eBay for $2. I don't care. Anyway, here's where I'd like to go this morning. I want to talk about what is overdiagnosis, define the term. I want to talk about 4 mechanisms by which it happens. We change the rules. We refers to the medical profession or the medical industrial complex, if you will. We are able to see more, we look harder, and we stumble onto things. And then hopefully I'll help us move forward or think about moving forward. What is overdiagnosis? Well, it's the detection of an asymptomatic abnormality or condition that either A, will never progress, or in fact will regress, or B, will progress slowly enough that the patient dies of other causes before symptoms appear. So you can see symptoms are a key part of this equation. We're talking about making diagnoses in people who are never destined to experience the disease. Now, note that overdiagnosis is typically a side effect of what we've been taught to believe is the right way to practice medicine. Detect and treat disorders before they cause problems. It's that paradigm that leads us to this problem. I want to be clear, there's nothing simple here. There's a conundrum here. Clinicians can never know who's overdiagnosed at the time of diagnosis. I mean, we have some hints. Overdiagnosis can only be confirmed in an individual if that individual is A, never treated, and B, goes on to die from some other cause. So it's hard to make this inference in an individual. So because it's hard to know, we tend to treat everybody, and that produces the major harm of overdiagnosis. Treatment that cannot help because there's nothing to fix. Treatment that can only lead to harm. And the reality is all of our treatments have some harm. Clearly some more than others, but they all have some downsides. So the question is, how did we get here? What's the genesis of this problem? And I'd say the genesis of this problem is in the detection and treatment of hypertension. And this is the point at which I get nervous in terms of public health and medical audience. He's going to say something like, don't treat hypertension. My God, I thought that was the most important thing we do. It is one of the most important things we do. But it's also true we can do it too much. Let's go back in time a little bit and look at one of the classic randomized trials in this country. It's in 1967. It's a VA cooperative study that's going to recruit patients. And they're all going to be men. It's a VA trial with, well, that'll be hard. There we go. With diastolic blood pressure elevation in the hospital. They have to pass a test of outpatient compliance, and their average outpatient diastolic blood pressure was 115 to 129. Wow, that's right. This should be clear for you. We're talking about the bottom number here, right? I know some of you may be confused. Are we talking systolic? No, we're talking about the bottom number. Okay, they're going to be randomized into 2 groups. The 2-drug group is getting hydrochlorothiazide and reserpine. The placebo group, they're going to be followed forward in time for a measly 1.5 years. That's not very long. Let's look at the outcomes. So, it's not even that big. It's less than 150 patients followed for a year and a half. What can we learn from this? Well, in the placebo group, there are 4 deaths. In the 2-drug group, there are none. There are 4 strokes in the placebo group. There is 1 in the 2-drug group. There are 4 cases of congestive heart failure in the placebo group. There was none in the 2-drug group. Placebo group had 2 heart attacks, none in treatment. 3 cases of renal failure, none in treatment. 7 retinal hemorrhages, none in the treated group. There are 3 patients hospitalized for high blood pressure, none in the treatment group. Treatment complication, did giving a sugar pill lead to a complication? No, it did not. In the 2 drug group, there was 1. I know that's a lot of numbers, I just want to give you a feel for the outcomes. Do you want to be treated for really high diastolic blood pressure? No. I'll do the math for you. That's 27 events that I think we care about in a year and a half versus 2. You know what I like about this trial? You don't need a statistician. Right? That's a huge effect. We don't see stuff like that very often. By the way, I want to come back to this idea of passing a test of outpatient compliance. The VA investigators were really careful. They wanted to make sure people would in fact take their medicines. So what they did is they gave people, before they were randomized, before they were eligible for randomization, they had to be given 2 placebos, one of which makes the urine fluoresce. They were seen twice in follow-up to count pills to make sure patients were taking their pills, and they had a urine test to make sure their urine fluoresced. They were really careful. Nearly half the veterans failed at this step. For context, now compliance rates in randomized trials or something like this would be about 90–95%. What was different? This was a time when people didn't take medicines when they felt well. You only took medicines if you felt sick. It was a new idea, taking medicines when you felt well. It was a real paradigm shift. That's why I say hypertension marks the beginning of intervention on asymptomatic patients. And it's a good thing. This was a good thing. But then we changed the rules. And by changing the rules, I mean we have lower diagnostic and treatment thresholds. The point at which we intervene is changing over time. When I was in medical school, the definition of hypertension was based solely on the bottom number, and we only treated people with blood pressures, with diastolic blood pressures greater than 100. Now we say anything greater than 140/90 is high blood pressure and needs to be treated. And we're measuring doctors on this. This is my VA kind of feedback I get. I get something on severe blood pressure control. I like knowing that. I like the electronic medical record, see who has really high blood pressure. But then I get some moderate numbers. I get numbers like this, and you can't see it. 142/64, 78-year-old male. Am I supposed to do something about that? Here's another one, 144/68. I'll tell you a little bit about this gentleman. He's an 82-year-old Vermonter. He lives by himself. He's about a mile from the nearest neighbor. As I say, he lives alone. He loves to work outside. He builds stone walls. He taps trees. He clears brush. He uses a chainsaw. And he's already fallen before because of blood pressure medications. Am I supposed to treat him more? Are you kidding me? By the way, the views expressed here tonight. I think a lot of good things are happening with electronic medical records. I think a lot of good things, despite recent publicity, good things have happened in the VA. But I am very nervous about blunt performance measures leading doctors to do things that they otherwise wouldn't do, because they don't think it's in their patient's best interest. Now, why do I say something like that? Well, because we have some sense of the effect of treatment across the spectrum of diastolic hypertension. And this is the spectrum, and I'm going to show you 4 randomized trials. Very mild diastolic hypertension, mild, moderate, severe. There's a little overlap here, it's real data, but I consider that the spectrum of the disease, the spectrum of abnormality. And on the y-axis, I'll put the annual rate of death or end organ damage. If you're wondering what that means, that's why I went over those VA outcomes so carefully with you. So you had some idea. We're talking about things that we care about: heart attack, stroke, kidney failure. And here is what's happening in the control group in those trials, and none of that will surprise you. Who is most likely to have those deaths and end organ failure? Well, it's the people with really, really high blood pressure. What happens in the placebo group? Well, these are the placebo group, fine. This is the intervention group. And you might say, why aren't they all at exactly the same level? Well, because they're real data. Real data look like this. But the main reason to put those two bars up there is so you have some sense of the benefit of treatment. The benefit of treatment is moving from one bar, from a red bar to a yellow bar. It's that difference there, the so-called absolute risk reduction. Let me take the noise away and just sort of give you what I think the big picture is. And maybe this is a long run for a short slide. Who really gets a lot from blood pressure treatment? Someone with really, really high blood pressure. So let me just generalize this. You know, you have a spectrum of abnormality from mild to severe, and we're talking about borderline hypertension to severe hypertension. All I'm saying is treatment benefit is strongly related to where you are on the spectrum of abnormality. People with the more severe abnormalities are the one who stands the most to benefit. Now I've got to put a treatment harm curve up here, so I'll just start, because all of our treatments have some harms. And I know immediately someone might say, wait a minute, I think the slope on that is wrong. I think it should go down like this, because who's most likely to be put in a position where they fall because I lower their blood pressure too much? Someone whose blood pressure isn't too high to begin with. But we could debate exactly where this curve is. But my argument is that it's less tightly related to where you are on the spectrum of disease, the spectrum of abnormality, than is the treatment benefit. That it's more a fixed effect of treatment and is less tightly related to where you are on the spectrum of abnormality. If that's true, there's certainly going to be an area with net benefit on one side. But at some point, you have to worry about an area of net harm. And we could, exactly where that point is certainly a legitimate topic of debate. But at some point, the chance for benefit becomes so small that it's going to be overwhelmed by whatever harm is involved in the treatment. So, we're measuring docs, we're encouraging to lower blood pressures. We're quite aggressive in diabetic patients. There's an interest to get, in JNC7, to get their systolic blood pressures down below 130. And the American Diabetes Association even went further. They said there's no threshold value for blood pressure. None? Are you kidding me? There's none? Just take them down to zero? I don't think so. So imagine in the past that we were trying to get diabetics' blood pressure down to 140. But then someone says, no, we should get it down to more like an average of 120. What does that mean? Well, it means a couple of things. First, the number of affected individuals. All of a sudden, you're treating more patients. And by the way, that number may go up quite dramatically, even with small changes, as you begin to hit the population mean. And who are all these new patients, the 130s and so forth? Well, they're the patients that stand the least to benefit and arguably at the highest risk for net harm. Well, here's a study that actually looked at that. This is the INVEST study, the International Verapamil Trandolapril study in patients with diabetes and coronary artery disease. And what I'm now showing you is all-cause mortality as a function of how much the doctors lowered their systolic blood pressure. The reference group is 125 over 130. If you get them down to 120 to 125, you don't see any effect. 115 to 120, that's still all statistical noise. Oh, that's a little worrisome, right? It's about a 70% increase in all-cause mortality. P-value is probably 0.07. Oh, that's definitely not good, right? That's over a two-fold increase in all-cause mortality is statistically significant. Why are we surprised? It's not that good to have a blood pressure that's too low. And amazingly, then things changed. This was from about 2 years ago. New diabetes guidelines eased the systolic blood pressure target. It was the first time in my career I saw thresholds being raised. Used to be less than 130, now it's less than 140. And then last year, there's a suggestion that hypertension guidelines can be eased for all of us. For people my age, about 60, instead of trying to get below 140, maybe it's good enough to not even bother people unless they're over 150. That's a big change. I think that's a good thing. I think medicine's in the midst of a rebalancing about the threshold to treat high blood pressure. But it's not just about high blood pressure. It's about diabetes. When I was in medical school, the definition of diabetes was a fasting blood sugar greater than 140. And then overnight, it changed about 15 years ago to a fasting blood sugar greater than 126. When I was a resident, our hemoglobin A1C goal was somewhere between 7 and 8%. And then someone said, no, we should try to make diabetics look like normal patients. Let's get their hemoglobin A1Cs down to 6%, like a normal patient. Well, what's the effect? Well, again, you got more patients to treat, right? The patient that's at 6.5 wasn't a patient, but all of a sudden becomes one. Who are the new patients? They're the people who arguably stand the least to gain and are at highest risk for net harm. Is that just a theoretical concern? Well, here's an interesting study from the Lancet 2010. Is good control good for patients? This is from the British General Practitioner Database. 48,000 patients with established diagnosis of type 2 diabetes undergoing intensification of therapy to improve glucose control. They needed better glucose control. Their mean hemoglobin A1C is 9.5%. Intensification means the addition of more oral medicines or the addition of insulin. The exposure here will be the mean hemoglobin A1C following the intensification of therapy. I like to think of this exposure as how well did the doctors do at lowering these patients' blood sugar. The outcome will be the rate of death from any cause. Here's the most complex graph I'll show you this morning. The mean hemoglobin A1C following the intensification of therapy. This is the exposure of how well did the doctors do at lowering their blood sugar. Y-axis will be the relative rate of death from all causes. You know, one's the magic number. Anything above 1 represents increased risk of death. Anything below 1 is decreased risk of death. The referent group is right in the middle of 7 and 8, 7.5. That's the old goal when I was a resident. If you can't quite get into 7.5, what do you see? Well, you see a little increase in mortality. Although none of them are statistically significant, despite the fact there are over 200 deaths in each group. If you can't get them below 9, you see exactly what you expect to see. Increased mortality. There's no question. It's bad to have really high levels of blood sugar. But how about if you drive them to normal? Do you lower their risk of death? No. You increase their risk of death. And it's statistically significant. A finding that was confirmed in a randomized trial in this country, which was stopped because of 25% increase in all-cause mortality. It's not that good to have glucose. It's too low. We can't dial it in exactly. If we're trying to get your average blood sugar to look normal, we're going to be taking you too low at some point. It's not just hypertension and diabetes. Cholesterol. When I was a medical student, the definition of high cholesterol is someone with a really high cholesterol, higher than 300. Now, having I'm overplaying my hand. But, it's anything greater than 200. And I know we fractionate it, but no one here will doubt that our threshold to intervene on cholesterol has changed dramatically. And then osteoporosis used to be defined as a T-score less than minus 2.5. I'm sorry, negative numbers and decimals. And then overnight it's changed to less than minus 2.0. I mean, how much can that matter? A negative number of 0.5. How much do any of these things matter? Well, my colleagues and I looked at the distribution of these variables among Americans to try to get a sense. How much does this matter? The hypertension change reflects 13 million Americans. That's a lot of people. The diabetes definitional change turned 2 million Americans into diabetics overnight. The high cholesterol change, well, that's a huge number, right? That's 42 million because we're treating average cholesterols now as being elevated. That little change in osteoporosis just among women turned literally 7 million patients into having the disease overnight. These things matter. That's what I mean by changing the rules. And then we're able to see more. This is a chest x-ray. There's some residents in the room. They probably haven't seen one of these before. We used to use these things. Actually, that's a highly abnormal chest x-ray. It has a big mass. That's a 10-centimeter mass. That's how we used to diagnose lung cancer. This is a spiral CT scan. This is one section of the lung. It's been magnified. That is a small peripheral cancer. It's about 1 centimeter in size. Couldn't be seen on chest x-ray. The lower limit of chest x-ray resolution is about 3 centimeters. Now the one thing we know is there are a whole lot more of these than there are of those. So here we're not changing the rules. The technology is changing the rules for us. Boy, this is an oldie but goodie. This is an air contrast barium enema.
Yeah.
Remember those? Yeah, okay. Everyone see where the abnormality is? There's a hint up there. All right, I'll fill it in for you. It's a filling defect. This is a large polyp. And this is the way we used to screen for colon cancer. That's about a 10 centimeter polyp. And you know, this is not what we do now. We do this. This is a colonoscopy. That's a 1 centimeter polyp. This is a virtual colonoscopy of the same lesion. Again, a 1 centimeter polyp. And again, we know there are a whole lot more of those than there are of the 10 centimeter size. And by the way, our gastroenterology colleagues are removing things much smaller than that. They're, you know, 0.5 centimeter polyps, 0.3 centimeter polyps, and then they're talking about flat polyps. I never understood that, flat. But I'm a general practitioner. I don't know what a flat polyp is. Okay. But there are a lot more of them. The technology is changing the rules. This is a mammogram. You know, it's a plain film X-ray of the breast. It's archaic technology. It was used in the 1960s in the health insurance plan in New York. Could it see a cancer? Absolutely. There's a 2 centimeter cancer. This is a modern digital mammogram. Can you see the abnormality? Well, you'd be forgiven if you can't see it because it's literally pixels in size. It's about 0.02 centimeters. These are the microcalcifications associated with the earliest form of breast cancer, the form of breast cancer that some pathologists wish the word carcinoma was never attached to, ductal carcinoma in situ. And again, there are going to be a lot more of these. What does it mean for us to be able to see more? If we're able to see more, what does that mean? Well, let me ask you a apparently off-the-wall question. How many lakes are there in the state of Utah? Now, I haven't forgotten, I'm in Virginia. I do know that, so I'll give you a little help. Utah is over there. How many lakes do you see? One. What is it? Who's been in it? All right, yeah, that's a great. Yeah, there's one, and you can see it from space. The astronauts can see it. But let's go in and take a look at the state level view. Well, oh my gosh, there's more than one lake. There's the Great Salt Lake north of Salt Lake City, but down by Provo there's Utah Lake, and the best lake to go visit if you go to Utah is Bear Lake up on the Idaho border. It's a very, very nice, beautiful lake. So there are 3 at the state level. But let's look into one of my favorite mountain ranges, one of the few east-west mountain ranges in the country, the High Uinta, and just take a look at about a 6 by 3 mile aerial shot of the High Uinta. Boy, there's a lot of lakes in there, aren't there? Some of them have fish in them, for those of you who like to fish, and they're good swimming. There's just a lot of lakes. Wow. So how many lakes are there in the state of Utah? Well, at the continental view, there's 1. You go down the state level view, and there's 3. But you go down to just one section in the High Uinta, and you've got 39 plus. How many lakes are there in the state of Utah? Well, the answer depends on the resolution of the map. Right? It's a function of what your map looks like. But you can make some general principles out that as you're able to see more, you find more. That only works in one direction. As you can see more, you find more. But the typical lake gets a lot smaller. The average lake declines in size and arguably gets a lot less important. So at this point you're wondering, okay, is this a geography lesson? What is this? Why did I come here? What does this have to do with medicine? Well, I think of this as our history and physical exam, right? It's looking for big things that are bothering patients, overt signs of disease. This is more like the chest x-ray, and this is the spiral CT. And we have to be clear about how that change in what it's able to see begins to affect what it is we find. Here's an unbelievable study. How many people have had a stroke? This is from the Framingham Heart Study. And it's still doing work, and it's now doing MRIs on asymptomatic people. In the 70 to 89-year age group, 15% of people who've had no symptoms, nonetheless, have MRI evidence of a stroke. 60 to 69, 10% of the population has evidence of a stroke. My age group, this is scary, 8%. And if you're younger than me, don't feel any better, because 30 to 49, 7% have had a stroke. But all of a sudden you begin to wonder, what does the word stroke mean? When I was in medical school, we thought of it as having a physical manifestation, of having some deficit. But now, if we let the machine define the disease, all of a sudden have we changed the definition of a lake to include a puddle? We have to really understand under what context does this word stroke come from? Does it come from a neurologic deficit, or does it come simply from a scan? The two things are not the same. And then we look harder. This is Medicare data. We do a lot of Medicare data at Dartmouth, and it's just looking at the pattern of image, cross-sectional imaging, and none of this will surprise you. Brain CTs have doubled over this period. Abdominal CTs up 3-fold, chest CTs up 5-fold, brain spine MRIs up 5-fold. That won't surprise you. Everyone knows we're imaging a lot more now than we used to. And then we encourage the well to get examined to determine if they're not, in fact, sick. Right? This is what we do. We encourage the well to get checked out. I gather it's happening right across the... Right, it's happening right across the way. What am I talking about? I'm talking about screening. And let me show you something that gets my blood pressure to dangerously high levels. It's a wonderful ad, really. A very attractive setup with little pixels of yellow, and a young, attractive woman, could be my daughter, and here's the script. It says, "It won't happen to me. I go to the gym every morning. I walk to the office, and I don't let work stress me out." A young woman doing all the right things for her health. And then in the small script beneath it, it says, "Alicia Fox, 21, the day before she was diagnosed with thyroid cancer." What's that ad designed to do? Is that a good thing for a healthcare system? It's designed to scare you. It's designed, and by the way, if the message is too subtle for you, it goes on. I'll put it up here. Confidence kills. That's a great public health message, isn't it? That's exactly the message we should be getting out to people. If you feel good about yourself, you're about to die. Right? I mean, that's like crazy. It goes on to say, thyroid cancer doesn't care how healthy you are. It can happen to anyone, including you. That's why it's the fastest growing cancer in the United States. It doesn't even make sense. Thyroid cancer doesn't care how healthy you are. It can happen to you, including that's why. It doesn't make sense. It says, ask your doctor to check your neck. And then, whoa. Wait a second, maybe there's an editing problem. Let's try that. Thyroid cancer doesn't care how healthy you are. It can happen to anyone, including you. Ask your doctor to check your neck. That's why it's the fastest growing in the United States. That's a little better. It was an editing problem. So what's going on in thyroid cancer? The next series of slides I'll show you are all from the SEER program, the federal government's main effort to track cancer incidence and mortality in this country. We're looking at the period of 75 to 2005. And we'll put the rates on the y-axis. Thyroid cancer was pretty stable until about the early 1990s, and then it took off, and it doubled over the next 10 years. Now, if this was an epidemic of disease, what would I expect to see happen to the rate of death? Well, I would expect to see some change in the rate of death, right? If there's more real bad thyroid cancer, I would expect to see the death rate go up. Or maybe I'd see it go up and then come down when we had a new test or a new treatment that could really change the underlying burden of disease. But in fact, what do I see? I see the most stable mortality rate in the SEER data. That doesn't look like an epidemic of disease. That looks more like an epidemic of diagnosis. And it's ongoing. You can see this ends in 2005. but in the next 5 years, it's now up threefold. And we're not even the #1 country here. South Korea has experienced a 15-fold increase in their rate of thyroid cancer. It's not from some exposure other than the exposure to handheld ultrasounds in hospitals and the screening program that has been encouraged by the medical sector. Thyroid cancer is now the most common cancer in Korea, more common than lung, more common than colon, more common than breast. It matters. It's not just thyroid cancer. Melanoma, stable mortality, but twofold increase over the period. Breast cancer, more complicated. Breast cancer mortality is going down a bit. That's good news. The question is, why is it going down? There's no question what happened to incidence with the advent of screening mammography. It went up about 60% in the population in general, went up higher in those women undergoing screening. And then there's prostate cancer, sort of the poster child for the problem. Prostate cancer mortality went up a little bit, then down a little bit. Nothing subtle in its incidence rate. This is a very unusual curve for cancer biology. We don't see curves like this a lot. Well, that's not true. We see them in other contexts. It tracks the NASDAQ quite well those years. You know, you can't explain a curve like this based on the biology of cancer. You have to know something about what's going on in the healthcare system. You can know all the cell biology you want. You have to know what happened in the healthcare system. That's the advent of PSA testing and then the sudden recognition that maybe we shouldn't be doing it in men who at least only have 10 years to live. I've always been clear, screening has benefits and harms. That's what makes it complex. It's not brain dead either way. It's not like I shut down the whole system, but it's also not like it's a free lunch. It comes with human costs. Let me give you the best sense of what I believe the trade-offs are now for screening mammography among 1,000 women aged 50. Undergoing annual mammography for 10 years, there are benefits and harms. The benefit is somewhere between 0.3 and 3.2 will avoid a breast cancer death. I know that's a little bit of a wide range. That reflects the absolute best finding ever in a randomized trial of screening. This reflects more like a 5% mortality reduction in breast cancer, which is what's sort of being observed by screening programs in Europe as they introduce the process. So somewhere in there the truth lies. That's an important benefit, but it accrues to a relatively few number of people. The harms in this country, this is only in this country, somewhere between 490 and 670 will have at least one false alarm in a 10-year course of annual mammography. Boy, that is outrageous as far as I'm concerned. You're dealing with a healthy population and you're alarming half of them in the process. No European country would tolerate that level of false alarms. Somewhere between 70 and 100 of whom will undergo a biopsy, some of whom will not be told they're normal, but told that they're abnormal, at high risk, that something's wrong, but it's not cancer, but we've got to keep following. And then the less familiar problem. Somewhere between 3 and 14 will be overdiagnosed and treated needlessly with surgery, radiation, and/or chemotherapy. Now, I can't look at these data and tell you what the right thing to do is. There isn't one right answer here. This is a close call that I think different people can look at and come to different conclusions about what they want to do. But I certainly have a question about this. Does it make sense that ensuring that all women do this has become one of the most prominent measures of how we assess how well the healthcare system is performing? I don't think so. I think the question of how well the healthcare system is performing is something about how well we're doing with sick patients. Now, let me take the false alarms off the table, because some people say, you know, Gil, you make too much of a deal, women don't care about it, it's not that big a deal. The psychological effects are not important. Let's just look at this ratio of the mortality benefit to the overdiagnosed harm, the treated unnecessary. It's somewhere between this, and I'm sorry there's such uncertainty, but there is. There's uncertainty both about the mortality benefit and about the size of the overdiagnosis. It's somewhere between 1 person versus 2 or 1 person versus 25. That's breast cancer screening. As many of you know, it's worse than prostate cancer screening. I believe there is a mortality benefit to prostate cancer screening, but it's small. The overdiagnosis problem is much more common. It's somewhere between 1 to 30 to 1 to 100. Now, let's ask this question. What does it mean to be a prostate or breast cancer survivor following screening? Now, I think the standard interpretation is on the left side of the slide. We're all thinking about these ones. His or her life was saved by the test. But you can see the more logical interpretation is that he or she was actually more likely to be overdiagnosed. Now, this is a huge problem for rationalizing the system because, in fact, the major harm of screening is interpreted as a benefit. And ironically, some people have pointed out that the more overdiagnosis a screening program causes, the more popular the screening test becomes. Here's how it plays out. The more intensively we screen, by that I mean the more frequently we screen, the more resolution we have, the more abnormalities we can detect, the more overdiagnosis that occurs. The more overdiagnosis that occurs, the more survivor stories appear. The more likely it is patients have heard one, read one, or more powerfully, know one. The more useful screening appears to be, because every survivor story is interpreted as being a beneficial effect of screening. And that feeds back to more intensive screening, leading to what's been dubbed the popularity paradox. And finally, we stumble onto things. We're doing all these exams, we're looking for X, and then we find Y. And we even have a name for this, incidental illness. Here's a powerful anecdote you don't often hear. An 85-year-old man who reports excellent health goes in for an annual physical. This was told to me by a doctor in Boston about his father. His doctor performs a careful physical exam and thinks he feels an abdominal aortic aneurysm, orders an ultrasound. The ultrasound shows the aorta is normal, but does suggest there's a mass in the pancreas, and a CT of the abdomen is recommended. The CT shows a normal pancreas, but also shows a liver nodule, and a needle biopsy is recommended. Needle biopsy shows a hemangioma and makes it bleed. Patient requires a week of hospitalization, 6 to 8 units of blood, develops urinary retention following narcotics for pain. Total cost of the annual physical, $50,000. This patient could have died. He did not. But this was a whole train of events that spiraled out of control. It's hard to find a medical error here. Instead, the cascade of events was all intended to help avoid a future problem, particularly cancer. But it ends up causing a problem now. Simply finding out whether a cancer is present will produce some harm, because ultimately we have to get some tissue. Even if a cancer is present, it's much more likely to represent overdiagnosis than a deadly cancer. And even if it is a deadly cancer, the chance we happen to stumble on it at just the right time when we can make a difference is extraordinarily low. That's why I think incidental illnesses are a huge problem for modern medicine. Why do I say overdiagnosis is so common? Because we had a little flurry of experience with whole body CT scanning. In asymptomatic volunteers, mean age 54, they're wealthy, they can pay for the test, it's about $1,000, and the radiologist kept track of it, and 86% had at least one abnormality. The average patient had 2.8 abnormalities. And I think that explains the last graph I'm going to show you. This is renal cell carcinoma. It has a very stable mortality rate, but there's nothing stable about the incidence rate. It's doubled over the period. This isn't because we're screening for kidney cancer, it's because we're stumbling onto it. So let me end by moving forward. This has been a big shift in paradigms. The old paradigm was to make diagnoses in patients who are experiencing problems. The new paradigm is to seek diagnoses in patients who are not experiencing problems. That's what I mean by early diagnosis. And I want to be clear, the paradigm of early diagnosis is not always wrong. We'd rather repair a deep laceration in the skin soon after it occurs than wait until infection sets in. We'd rather see patients early in the course of their pneumonia than wait till they develop dyspnea, and sepsis. We'd rather see patients early in the course of their heart attack than wait till they develop arrhythmias and hypotension. And we'd rather see patients with a small breast lump than wait till women develop a large breast mass. The question I'm raising is, to what extent should we get ahead of symptoms? How early? In the past, doctors treated a population, we waited for problems to develop. We didn't even think about the population. We waited till people had problems, and then we diagnosed and treated. The early diagnosis ideal was to take that same population, advance in time those destined to develop the disease, with the belief that the natural history is those would be the people destined to develop problems. But that was the ideal. The reality was quite different. Every time we started an early diagnosis, we found more patients. That implies the natural history's got to be a little different, a little bit more complex. Hopefully we found those destined to develop problems, but we found a new subset, a new fraction, those not destined to develop problems. And they're the overdiagnosed and needlessly treated. I want to be clear, nothing good can happen to this group. All experience the impact of diagnosis, the labeling, the sense of vulnerability, which may be very important to the very resilience that we think health is. And until the president had a plan for this, it could throw away your insurance. You know, a new diagnosis might change how much you had to pay or whether you even could have insurance. Most people experience the impact of intervention, the so-called hassle factors, subsequent appointments, more testing, surveillance, phone calls, filling scripts, and then some people experience harm from the intervention, side effects from medications, surgical complications, even death. How did we get here? Or the real American question, who is to blame? If you remember my generation, this is the guy you always target. And it works. Richard Nixon did say we need to work out a system that includes a greater emphasis on preventive care. This was part of the HMO Act, and it was part of the war on cancer. And I think what we have here is a failure to understand what prevention means. There's two very different types of prevention that's good for us to separate out. Preventive medicine can mean health promotion, or it can mean early diagnosis. Early diagnosis is what a test might tell you. I like to think of my 1999 Volvo. Are you guys familiar with this light? Right? It's checking about 200 functions, even though the car's 15 years old. You know, it's checking all sorts of things, even though the car's running fine. In fact, this is what the dashboard looks like now. I've got lights everywhere. Oh, and then in my wife's Subaru, we just recently got a check engine light, but there's a new feature now. When the check engine light comes on, all of a sudden the cruise control light starts flashing. It disables your cruise control. Why would they do that?
What year is your Subaru?
Yeah, it's 2005. They want you to bring it in. They want you to bring it in. And we should learn something from Subaru. If you don't get a mammogram, I'm going to stop treating your really high blood pressure. Health promotion, it's what your grandmother would have told you. You know, here I am, it's not the greatest picture ever. But, you know, health promotion in your car, it's changing the oil, it's keeping the tires inflated, it's washing the salt off your car. What is it in health? What would your grandmother have told you? Get plenty of sleep, eat your fruits and vegetables, go play outside, and don't start smoking. It's not very sexy, it's not very high-tech, but we all know it's pretty important stuff. The basic idea is pretty positive. Be healthy. The basic idea here is less positive. It's looking hard for things to be wrong. And the question I want to leave you with is, looking hard for things to be wrong a good thing for the healthcare system to do? Thank you very much for your attention. I'll be happy
I was misdiagnosed many years ago with lupus. I told them I did not have lupus. They just wouldn't listen. And then because of that, we had more blood work. So then my anticardiolipin came back positive. So I was put on Coumadin, like 10 milligrams and 12.5 alternating for many years. Then I came to UVA, and Dr. Masick said it was a false positive, did all kinds of tests, got me off the Coumadin. Then I saw the rheumatologist. He said I didn't have lupus. I had some kind of connective tissue disease that they don't know anything about. So So I had echoes, I had Holter monitors, I had all these things, just because I had neck pain because of an accident.
I'm sorry, and I'm glad you're on the right track.
And please identify yourself when you ask a question.
I'm Carolyn Engelhardt. I teach health policy. This was great, Gil. I knew it would be.
Thank you.
But it sounds to me like you're asking us to go forward by going backwards. And my observation is that technology may be telling us too much, but science is telling us too little. And since we know how politicized this can be, just as Kathleen Sebelius on the mammogram recommendations, is there a way that science research can get us out of this conundrum so that we're never going to get people to turn off the imaging? There's a way to better know when things are found, whether they'll just be benign and never go forward, or whether or not they will become the ones that will be life-threatening.
Let me start by, first, thank you for the question, and there are a lot of dimensions to it. I don't want to leave anybody with the impression I want to turn off the imaging. These images have been great for the care of acutely ill patients. We have made some real advances in being able to see the inside of the human body, and these are great things. It's all about how they're used. So there's no interest in turning things off, but there may be interest in using them more prudently and making sure you're in the setting in which you use these technologies, I think is very important. As to your question about, can science help us maybe mitigate some of the problems, the very first step to that is to understand that there are problems. And that's one of the first things to recognize, because if you don't understand the harms of overdiagnosis, you're driven to find more and more cancer in the case of cancer. You're driven in one direction. It's a single variable maximization problem, and that's what's led us to the problem with gut state. Anybody can find cancer. The question is, who can find the cancers that matter? And it's very important to understand the overdiagnosis problem, because I think it leads to the strategies that can mitigate it. And some of it is as simple, and that was one of the major rationales for this whole question of how frequently we screen people, or at what age we start screening, become very important to this calculation. But also the knowledge, once you know that some cancers don't matter, the ability to make use of things like time to sort of separate out which cancers do matter is a really important step for us. Even though it may seem like a very simple variable, adding time becomes really, really important. And that was done in the NLST, the National Lung Cancer Screening Trial, because they didn't want to overdiagnose too much lung cancer. They didn't want to remove too much pulmonary tissue. They said small lesions had to demonstrate growth before we'll biopsy them. And so that kind of approach is much more, is both informed by science, and it's actually much more able to distinguish things that are really going to be important and things that are not. It's making use of time.
I'm Preston Reynolds, Center for Biomedical Ethics and Humanities, and that was a brilliant talk, and I applaud you for your message. So my father's 89. He had a triple bypass 11 months ago. He was the first endocrinologist in his community. He sold his practice to the physician he now goes to. In his last visit, his doctor said, well, I want to check PSA, I want to check for MGUS, and I want to do a variety of other screening, check your lipids, hemoglobin A1C, whatever. And my father, a brilliant clinician, said, my diabetes is well under control, my lipids are well under control, I'm 89, we're not going to do anything with my PSA, and there's no reason to check me for MGUS. This is unconscionable. And haven't you heard about this new thing called high-value care that my daughter's involved with? And his internist responds back, I'm an internist. I'm supposed to look for problems. That's the definition of how I'm trained. And that whole high value care initiative I think is bad doctoring. So my dad says, well, I would fire you as my doctor, except it's hard enough to get an internist, and I do need some continuity of care. He says, but let me ask you, I sold my practice to you, I really want to know why you're doing this. He said, I have productivity targets, and unless I make them, I will not be able to maintain my salary and have any chance of a salary increase. So I'm doing what I'm doing for purely financial incentive reasons. And my dad said, well, I still think we don't need any of these tests. And they still got ordered anyway.
Am I to comment? If the question is, do I think money's part of this story? Oh, absolutely. Absolutely. And that money may be money to the medical center or maybe money to the individual physician. Do I think money's all of this story? No. I mean, if my colleagues would want me to bring lawyers into it very quickly, so I'll tag the lawyers in the room. But
here, Gil.
and oh, there you are. Okay. But I think there's other things too. There's true belief. You know, the simple idea that of course early detection must be good. I want more. There's also the whole information flow from the media and advertising that's constantly supporting the message. So rebalancing the system does take new financial incentives. We're very interested in those. It also takes, I think, educating the general public to have a little bit more realistic view of what medicine can and cannot do. That that it's very useful for people who are acutely ill and actively suffering in general. That it's a much closer call when you're well, to what extent you want to be involved with the healthcare system, that there may be pluses, but there may also be minuses. So part of it is I think, helping the general public have a better understanding about the benefits and harms of medical care, and recognizing that we have exaggerated our benefits and probably downplayed the harms of the process. So there's a lot of things that need to be done along with getting rid of the lawyers.
Go ahead.
Yes, sir.
Yeah. Well,
Oh,
no, we
I'm
need
sorry. I'm calling
somebody
people
with
here.
the mic,
Sorry.
so, yeah, go ahead.
Doctor, my name is Gabe. I'm one of the chaplains actually in the hospital. And I'm wondering if overdiagnosis is related to something that we've been made aware of months probably ago. Excuse me, when a popular actress, in a way to sort of intervene on the possibility that she will have breast cancer, had a double mastectomy done.
Well, you're talking about Angelina Jolie, I assume, and I think, and I wrote an op-ed immediately following her op-ed to be clear that, you know, I think she made a rational choice. I don't think she made the only choice. Let's be clear. She is not representative of most American women. She's representative of less than 1% of American women. She has one of the few genes that really has a fairly substantial penetrance. And I think she made not the right decision, but a perfectly rational decision based on her preferences. My problem with her op-ed is she wasn't clear enough that she didn't represent many women. She represented the women who had BRCA1 or BRCA2. Your general point is, do celebrities, do visible public figures have great influence over the public? Yes, they do. And we have to be very careful about interpreting their stories. And I'm thinking of Arnold Palmer with prostate cancer. I mean, he was in General Schwarzenegger. You know, they really helped the PSA train get going. And we need to help inoculate the public from the survivor stories or the stories that back surgery helped. You know, because you don't know what would have happened if back surgery wasn't done. You know, this simple observation that people who do well following medical care must be the result of medical care as opposed to the natural history of their disease is something we need to help the public understand. But they're very powerful. The celebrity stories are very powerful.
I'm afraid we're out of time, so we'll let Gil take some questions since he's up with the bookstore people outside the auditorium.
And I'm going to take your question.
Yeah, and I'd like to thank the Sadie Lewis Webb Program in Health Law, the Department of Public Health Sciences, and the Institute for Practical Ethics and Public Life for co-sponsoring today's program. Join us next week for Landscapes of Longevity, which will include clips from a documentary film by the same name, and we'll talk about successful aging, healthy aging in different parts of the world. Thank you, and thanks to Gilbert Welch.